You're listening to The Q Switch with your host, Spence.
Welcome, one and all, to the Q Switch Conversations podcast. I'm your host, Spence, and the mission of this show is to tackle subjects currently impacting ophthalmology, where we invite the innovators, thought leaders, and forward thinkers shaping the field of ophthalmology to discuss their unique perspectives. So let's jump right in. In this episode titled Floaters, Facilities, and the Future, we welcome Dr. Chris Wood, who's been serving the Arlington Heights community and the greater Chicagoland region for nearly 3 decades, long enough to witness the transition from PMMA lenses to premium IOLs, from paper charts to AI-powered diagnostics, and from hospital-only cataract surgery to office-based surgery innovation. He's a board-certified ophthalmologist, owner and president of Northwest Eye Physicians, and a pioneer in office-based cataract surgery through his partnership with IOR Partners, and a consultant to Luminous on their floater laser technology. He performs advanced cataract surgery, MIGS, refractive procedures, eyelid surgery, and YAG vitreolysis. And when he's not reshaping the future of ophthalmology, he's reshaping the air with his trombone in a semi-professional ensemble throughout Chicago. In other words, he understands both precision optics and perfect pitch. Dr. Wood, pleased to have you join the Q Switch this afternoon. Welcome to the show.
Thank you. Nice to meet you.
Hey, so Dr. Wood, you've been serving patients in Chicago for over 28 years. When you look back at your early days in practice compared to today, what stands out as the most dramatic shift in ophthalmology?
Well, I would say the degree of customization is much better than what I had when we started, and the ability to hit our refractive targets in cataract surgery is now quite amazing. And one other thing that we're focusing on this discussion is the treatment of floaters. And that's still evolving, but I think we're seeing the path to the end of that. And I'm going to talk about the laser part of it today.
Yep, of course. And then so building on that, how have advances in diagnostic equipment, OCT, topography, biometry imaging, changed the way you evaluate and counsel patients?
Well, again, I had much more data than I had when I started 30 years ago. And I can really educate them a lot better when we get started. I have 2 screens, one with data and one with images. And I kind of go through it and show them my work and then send them videos. I can much better educate patients than when I started. And also so the latest thing I've been doing with floaters is using an Optos image to show them exactly where their floater is. And I say, that's what we did. And I'll show them later, this is how it's gotten better. They know it's gotten better, but I can confirm it with them. And I mean, I can do the same with refractive targets. They're not as keen on the refractive target thing other than they can see well. But with the floaters, there's a measurable improvement that I can show them on the image, which is good.
If we zoom in on intraocular lenses specifically, how has the conversation around premium IOLs evolved from a technology perspective and from a patient expectation standpoint?
So for premium IOLs, well, first of all, most patients don't really know their options at all. We do try to pre-educate them. We give them a navigate call now, and we send them some videos, but really it helps the patient to trust the doctor. You need a trust visit. And if they're not quite ready, you do a lock visit after that to make sure that they know their options. And it's just very important to discern beforehand and after, if they know what they want and how to get there, and give them a path to get there. And if they're not where they want to be, that, we fix that when the patients, if they're dissatisfied afterwards, if there's a way to fix it, we try to fix it. So I kind of look at it from both ends. I look at it from the front side and the back side. And we have so many options now, and I tell patients it's confusing for us as providers because there's way too many options,
Yeah.
Right? But I try to discern for my patient the best for them, because there's certain things that work better for different patients, whether it's monovision or different types of multifocals or EDOF lenses. We go through all that, or light adjustable. I mean, there's pluses and minuses to all these things. And, in addition to cost, you want to go through all the pluses and minuses of what they might be dealing with afterwards. So we kind of do that. And I make sure I tell a patient that every patient's different, every eye's different, so we can't easily generalize from one to the other. And that builds trust, because then you're indicating that, some of this we can't control for. And if there's a problem, we're going to work on it.
So you mentioned 2 things as you kind of really detailed your approach. You called it a trust visit and a lock visit.
Yes.
And how did you come up with that kind of, terminology and that format on being able to manage the patient journey and their expectations along the way?
So the trust is, if it's a brand new patient, they have to build trust in you. They don't know you as a provider or a human. And you have to build that trust with them by showing empathy and interest in their particular situation. And that may take a couple visits. Okay, so you don't want to rush that. And it's like a sales thing where you have to build that trust over time. And we're not good as doctors at selling things. We're good at doing things. And one thing I learned about selling is that there's what is it? There's three things. There's features, which we get obsessed about as techie people, and then there's benefits, which patients want, and the cost, which they also want to know. But the benefits have to justify the cost, right? So we kind of did all those things. And you can't, if you've just confused somebody with a whole bunch of words that they don't understand, you're not at a trust point, So you want to pre-educate them if you can with a call, with a navigate call, with either, we outsource it, but you could have one of your staff do it. And then if they're not, the other thing, if they're not a decision maker, you want to make sure that they're comfortably making that decision. It might involve having a friend or family member with them, when they come in.
Mm-hmm.
So this is sales stuff. This isn't technology, right? This is sales.
Yeah, and I would say that, when you first started, because I think partly because there weren't as many options and things you could do to really customize a patient's vision and outcomes, that you didn't have to really get into, if you want to call it, the sales aspect of, your practice. But I think in recent years, being able to be a salesperson, have a sales department, if you will, is almost a necessary part of being able to be successful, not only educating patients, but also pulling them through to make those decisions and again, benefit not only the patient, but also the practice from a business standpoint.
That is correct. And, I'm not a salesperson, really. I don't consider myself a salesperson, but I've gotten good at presenting value propositions, right? Because it's all about value. And also the premium. Now we have an office-based surgery suite. We got started in 2022. So about 3.5 years, we've had the OBS suite, and that is now a premium experience. And you can sort of sell that on the first visit. If they don't even know what that is, you have to create this vision for them that they literally and figuratively don't have yet of what this could be, right? In terms of the experience and the outcome. We've only ever focused on the outcome, right? Does anybody focus on the experience in healthcare unless you're doing boutique stuff? I don't think so.
Not really. It's I think starting to catch on and realize that it's kind of a necessary part of how you meet patient expectations in the journey. Others who were out in front, sounds like you have, and anybody with an OBS, I think it's part of the calculus.
It is. And it's not something you would think you needed as a doctor, because we're just so focused on technology and results and flow, and not as much on what the patient's experience is. And I've been focusing on customer service for a long time, but then the problem with customer service and focusing on that is that your team feels neglected, because now you're focusing on the customer and not your team. So you have to do a team focus too, and customer. It's very complicated, these management things. And then in the OBS suite, you can engage parts of your team who now feel like they're doing great work, because now they're doing all the surgical work that they couldn't do before. But that adds stress too, because now you've got pieces of your team being pulled away to do that. But hopefully you have a big enough team, you grow a big enough team that you can have everything working on all cylinders. And that's what we've been working on.
Next question. Now we're entering the AI era. Where are you seeing artificial intelligence meaningfully impacting ophthalmology, and where do you think the hype may be outpacing the reality?
Well, I think AI has a lot of potential. It will never quite make up for human touch. Okay. So I can't imagine people being happy with robots doing everything for them in our office, but maybe. Depends on your neighborhood. Maybe in Silicon Valley they'll want that. I don't know. But around here in the Midwest, I think people like the human touch. I think AI is going to be helpful for diagnostics, for coming up with complicated diagnoses potentially, or following lots of data. We get lots and lots of data now. So sifting through that data and coming up with things, AI is going to be good for that. Lens calculations, educating patients. I mean, there's already a Dora AI from Euphonia in England, and it's coming here soon. I'm going to get beta tested on that as soon as I can, where it'll pre-educate the patient. Now, there needs to be work on it, because it has to be specifically designed to your talk track. and your specific patient demographic and dialect, right? So you got to make sure and that there's pauses appropriately, because like it's like talking to a voicemail thing. You want to make it a little more interactive and accessible to the patient. So that will come, but that would be great to have, or pre and post surgical education, right? It'll just give them a call. You can call whenever you want. Dora's available anytime. Like, you don't have to wait for that person to be available. They're always available. So they can educate at least on basic things, and the 5 or 6 top questions they'll have. If it's something more complicated, it'll escalate to a human, right? So that's what we'll end up with. And in a better way than you'd have at Comcast or corporate, because we'll actually answer the phone if there's a problem. Right. So that's where I see AI going.
Speaking of evolution, you helped create the second office-based cataract surgery center in Illinois. What inspired that move into office-based surgery for you?
So I was a medical director at a corporate-owned surgery center in my town, which was actually interesting, the very first ASC in Illinois. That was the first one from the early 70s.
Oh, wow.
Yeah, and I was a medical director there, and, it kind of had that long trajectory down, and they couldn't get enough orthopedics in there. And they finally, after COVID and a bunch of other stuff, they ended up closing it. Now, I didn't want to go to the hospital next door because I'd been there before and it was very inefficient. It still is, but they have a surgery center there. So I didn't have an ownership interest anywhere. It was a perfect opportunity to get this OBS started. I'd already been talking to the owners at IOR, Rick Prell, Tony Burns, and we had just bought our building in 2021, at the end of 2021, so we had this extra space. And there was our architect had put in this multi-purpose room for us. It was like 18 by 30 feet. I'm like, I don't think we need that, but what else could we do with that? And I called up Rick Prell and I said, is this big enough for an OBS? And he said, oh, that's more than enough space. So they ended up getting me with Tony, and it was great. It's been just a wonderful experience having that in the practice. I operate nowhere else but my office now. I do my cataracts and OBS. Like this morning, I did probably 12 or 13 cataracts in the morning, had a nice lunch, and I did some stuff in the afternoon. I did a ptosis repair in the afternoon. I have another minor room where I have a laser minor, and then I got another laser room. So they got a lot of operating space over there. So I can do all my work in my office now. I don't have to go to the surgery center. My partner and our new MD are both cornea specialists, and they have to go to the ASC for cornea because of the tissue. You can't get tissue reimbursement in OBS, but ASC, they'll go there for a couple cataracts and a cornea procedure. That's typically what they do.
I would think having an OBS is the kind of thing in terms of the patient experience, being able to come to the same place to have their procedure or the surgery done as they've come to get their diagnostics and all their pre-work and post-op is somewhat convenient and very comforting for them, knowing that they're going to go to the same place and there's no chance for them like having to drive a farther distance or get lost. So I think there's an added layer of comfort for them moving forward with their procedure, knowing it's in the same place.
That's true. It does allow a little bit better upsell for premium, a lot better upsell, because you're having a premium experience too. But again, the patients don't know anything, right? So we kind of have to explain the benefits to them, right? You would assume that you would know that, but we know that because we're in the biz. Patients don't know that. They've never been to an ASC unless they were there for something else. And those who have had an ASC and then an OBS, they're much happier with the OBS. They require much less sedation. We only do oral sedation. I've had one blood pressure spike in 3.5 years? I mean, one blood pressure spike in pre-op. And then otherwise, if they get a high eye pressure, we just release some fluid from paracentesis in a room and they go home. It's like so easy. And these things that have been pinch points at the surgery center and problems are no longer there. Right.
When I started in ophthalmology, I was with Alcon in our pharma division. There was one doctor here in South Florida where I live. It's called Sight Trust, Dr. Schatz in Sunrise, and he had his own basically OBS. It was again, this is 2011, and it was super taboo. His clientele was like doctors, judges, lawyers, attorney, people with high net worth, celebrities, all the jocks in the area. Like And so he had, a lane for himself, and he had him picked up in town cars and limousines. He gave him the personal cell phone, champagne, the whole bit. It was like white glove, red carpet. I mean, really VIP situation. This is back in 2011. And so, but now it's common. I mean, OBS really has kind of really made it normal for just anybody who wants one, as long as their state is regulated to have it, can incorporate this into their practice. And now moving on to the next question, and you may have answered a little bit of this before, but what inefficiencies or frustrations in traditional ASCs or hospital settings does office-based cataract surgery actually solve?
So you don't have to deal with anesthesia services and not having them. You don't get patients canceling because they've had some weird, thing come up with their heart because they had stress in pre-op, and now they're over sedated. And I mean, there's just all sorts of things that we don't have to deal with. Nausea post-op, I never get that because they give them fentanyl. These are anesthesiology people. They're always pushing fentanyl, and it's bad. They don't know that because they don't have to see the patients afterwards. It's like, that's not good. So we just use Valium and Versed, and it takes care of that. The flow, I think our average, I have one room. If I had 2 rooms, I could be a lot faster, but economics dictated 1 room. So, but we have a LensX in that room, and it's like pretty seamless. You just do the LensX, get them over and get it done. I can probably do 2 LensX cases an hour or 3 standards. So it's not quite the same flow as you get in a 2-room ASC. You can do, 4 or 5 cases an hour, right? If you got 2 rooms in an ASC. But double the staff and, double the cost. So you just got to be careful what you wish for. And if you want to make it a premium experience, it's not about volume. It's about a premium experience, right? You have to kind of divorce yourself from that volume model and just go into the premium space. Even for your basic Medicare, I mean, because those people tell their friends, I think it's more like you're developing a word of mouth on this, and it takes a while. Word of mouth it's the best way to get patients, but it takes the longest to get there, right? It takes like years and years.
I mentioned Dr. Schatz. All his patients were referred, again, in the community, or like in the rooms at like ballrooms and all these places, like, these like, like the policeman's ball and all this kind of thing. And it was all referral. I mean, price wasn't an issue. I think he did maybe, what was the number? I think it was like 12 to 15 a week. Speaking of what you had just said, it's not about the volume. I mean, I'm sure he charged, a premium for each eye, but it was about the experience and, really met the patient where they were. It was that upper echelon. And I mean, again, there are still some of those around, but now again, we've really made it so that it's more accessible for just the regular Joe like myself, say.
Exactly. Yeah. I mean, within reason, there is an upcharge that IOR, requires that you charge to get up to where for your economics, but it's not a bad upcharge. And then there's premium on top of that. But what really drives the equation is the premium, and allowing for that premium experience gets you to a higher premium conversion.
Keeping it balanced, what are some of the limitations where does office-based surgery shine, and where must we still rely on traditional surgery centers?
So, as I said, for cornea, you can't get cornea tissue reimbursed outside of an ASC or a hospital. So for cornea, you need to do that. If you've got, complex retina, there's a couple retina specialists. I know Omar Shakir in Greenwich, Connecticut does a lot of he does retina in his office, and he's got an OBS, but he has everything. He's one of those unicorns where he does everything and retina.
Yeah.
So I said, when I talked to him initially, I said, that's not going to be easily generalizable for most people, but if working for you, that's great. But he's made it work. But for most retina, I feel like if it's a sick patient and you got a lot of comorbidity, you're better off having anesthesia monitoring the patient just to be safe. If it's a pediatric, you got to use it, right? You can't do peds and then OBS. If somebody's mentally challenged or mentally disabled, or they're phobic, and they can't handle it, you got to use more for that. I would argue for dementia patients and Parkinson's, OBS is better because you could do little to zero sedation. And you know what messes up these dementia and Parkinson's patients? It's extra sedation and definitely general. They are messed up for a long time if you do that.
Is that right?
Yeah, and you don't even think about that until you've done one and you're like, oh my gosh, I should never have done that. And now I just do these people with almost no sedation and they do just fine. And you're not messing them up for a cataract surgery, right? So you want to make sure you go light on those patients, and this will let you to go real light. You're asking me about the challenges. I mean, there's compliance issues because we're not fully regulated, and it's an extension of our license. We are accredited right now. We're going to go to JCO, but there's always changing landscape and regulation, and the state of Illinois does not regulate these yet. They will eventually. So there's this unknown regulatory part of it that will come into play. And then, occasionally you get patients that don't want to pay. We'll take it to the ASC, I guess. But my patients, we just tell them up front, you're going to pay this OBS fee. And because they're getting me, they're willing to pay that. Because they're getting a higher quality product too. It's not just that. And they don't even know about the experience. I just tell them once they get there, this is going to be the best experience you could ever have, but doing this. But then the other challenges would be, there's some insurance things that go into it. So, we work with insurance. The IOR's got a way of doing this. And there's, again, some compliance issues on that. But other than that, I mean, it's been nothing but a wonderful experience for our practice, I would say.
I know a number of surgeons and practices who have went the IOR route, and it has only been, it's freedom. It really does. It's only been an asset. Only positive things have happened with anyone who has decided to incorporate an IOR or an office-based, because I think there's other companies, not as many. I think IOR is the main one, but there are other companies that offer it too. But anybody who decides to get an office-based surgery center at their clinic, they do not regret it. And the only thing they regret is not doing it soon enough.
And you can combine ASC and OBS ownership. I mean, Paul Singh did up in Kenosha. He's got an ASC interest and an OBS. And I would think you would want to drive your premium to the OBS and do your MIGs and standard and MIGs and Medicare stuff in the ASC.
Right.
You can do that
right.
too.
Let's shift gears. Floaters. Almost everyone has them, but not everyone is debilitated by them. For listeners who may not treat them directly, why can floaters become such a quality of life issue?
So, we are very visual creatures. And so anything that gets in our way of our vision is going to be disturbing. And if you take the time and listen to your patients, which I encourage all my younger doctors to do, you will hear these things. If you are dismissive of their concern, then they blame themselves because they can't get used to it. That is the primary lesson I want to get across, is listen, and really listen to your patient. And I know that the standard of care has been and continues to be telling people that you'll get used to it. That's true for floaters, dysphotopsias, whatever, like things you get with glare and halos with multifocals. These get blown off all the time. These are nothing issues for the patient. And there's ways to address these things, right? You can do an IOL exchange if it's a bad IOL for them. Stick a silicone IOL in there. If it's a floater, what I try to do, I try to normalize it for the patient when they get into my chair, or my other doctors, if I have an optom seeing the patient, normalize the idea that you could treat this. Now, you will likely get used to this, right? You will likely, but it's just something where you can, you want to plant the seed that there's something you can do about that. That's what I would say. That's how I start with the approach. And it's not that this is suddenly come up. It's been there forever. It's just that we're starting to address it more openly, I think, as a group, or should be.
You've worked closely with laser platforms like those from Lumenis, Alex, and others. Walk us through how YAG vitreolysis works, what's happening optically and anatomically during the treatment.
Okay. So I learned this procedure from Jack Karakoff because at one of my meetings, I went to his poster presentation at the Academy, and I said, how do you do this? And he had written a book on it, and it's still out there. You can find it. And then he had a couple lenses that he made. And I've since switched to the Paul Singh lens. That's a really good lens because it gives you a broader view than Jack Karakoff. You get like a 20-degree view with this thing. And what I would encourage somebody new to this procedure to do is just get the Singh lens and put that on a patient's eye and just look at the floater at the slit lamp. Get comfortable with how that looks, XYZ. Finding the floater too, because it's sometimes hard to find it. It's usually down below with gravity, but sometimes it can be side or up. So, and then you need a laser that's specifically designed for this use. So you need, as far as I know, the LX, the Ultra Q with the little mirror that drops down, and the Luminous with a Smart V attachment are the two that I know of are designed for this use. Interestingly, they never got their FDA approvals extended from YAG capsulotomy and iridotomy. So you're doing it off label. In the EU, it is approved because the EU is more rational.
Is it really?
Yeah, it is approved in the EU. And
Didn't know
so it is reasonable to do it because these lasers were designed for this use, but you're still off label, so it's hard to promote it. When you put the lens on the eye at the laser, the settings, I mean, are basically I start with 5 millijoules, 2 pulse per burst, so essentially 10 millijoules, 100 to 200 microns posterior offset. And the general rules of thumb, well, you start in a pseudophakic patient before you do phakic. Start with a Weiss ring before you do an big anterior floater, right? Just start easy. So pseudophakic, Weiss ring right over the nerve, not on the nerve. You have to be at least 3 millimeters from vital structures like your macula and your vessels and your nerve. You want to stay away from that. But if you're mid-vitreous, which most of these are, you're going to start top to bottom, back to front, because as you start lasering, the bubbles will lift the floater, and your severing vitreous adhesions will push it back. So you want to start top to bottom, back to front, and you work your way down. As you get smaller pieces, you can go down to 1 pulse per burst and maybe a 0 offset to get more accuracy on that one spot. And you can get the little tiny pieces, and then you use external fixation to have the patient move their eye around and make sure you're not missing other pieces, right? And often there's a tandem floater where you've got a Weiss ring in the back and compacted vitreous in the front that you also have to address. So I tell the patients, you might need a second treatment if you see like a cloud afterwards. If I've taken care of the bug and there's still the cloud, we can work on the cloud later, or I try to thin it out when I'm there the first time. But that's like finer point stuff for later. But you basically just need to use one of those lasers designed for floater laser and get a Sing lens to get started, and just practice on the patient first in the chair. Also, don't offer it when they first come in. If they first come in and it's a new PVD, you got to make sure the retina's healthy. Make sure there's no retinal tears or bleeding, right? Or detachment. If they have a retinal tear, I laser the retina first. But if they don't have a retinal tear, I say, well, you might get a retinal tear. So I'll come back in a month or two and let's reevaluate this. I get an optos the first visit, and then I get a MAC OCT the second visit to make sure there's nothing weird attached to the fovea. Because I've seen one lamellar hole from this, which I think was from like a weird vitreal attachment to the fovea. But as long as it's fully detached, and you've got that Weiss ring there, you're going to be safe to laser all you want in the mid-vitreous. It's just when you get close to the retina or close to a human lens, then you got to be careful.
This is where nuance really matters, and I think you spoke to just a moment ago. How do you determine who is a good candidate for laser vitreolis and who is not?
Well, there's also a psychological component with this too, because I do get patients coming in for their third opinion who clearly are psychologically bothered by this beyond the reality. And you have to be careful to assess that as well, whether this is going to be good from the standpoint of you're now owning their problem. So I know the retina people are real leery about being known as the retina doctor who does floaterectomies because they are worried about this, the psychological component. So if the patient seems rational, I mean, you have to assess rationality here. If they seem rational and are not in a panicked state about this, then you can have a discussion with them. And again, it's about normalizing and assessing over time. So you first want to make sure the retina's okay, assess the retina, make sure everything's good there, and then have them wait 1 or 2 months and just say, look, it could be that you get used to this, but it's not your fault if you don't get used to this, and we can address this or find someone who can address this for you. What I'm seeing on social media now from the patient's perspective is they're all going for floaterectomies and they're bypassing the laser. Well, that's because nobody's offering them the laser to start. So we need to get better as general practitioners of ophthalmology at offering this procedure and getting good at it, or at least passable at it, so that we can offer that before they end up with a vitrectomy and a cataract.
For physicians considering offering this service, what equipment specifications are essential, and how important is formal training and mentorship before offering vitreolysis?
Well, I've taught myself a lot of things, including this. Good and bad, right? Because you want to have a good mentor to kind of get you through some pinch points, but nothing beats experience, right? As far as being a good educator. But I would say for technology, you're going to want, like I said, the LXQ, the Reflex Q, the Tango where it drops down, the little reflex mirror, or the Luminous with a Smart V attachment, which has a beam splitter. That way you get coaxial illumination, a super Gaussian laser distribution with a very minimal cavitation profile. And those are built into those two lasers. So that's what you're going to want. Your average, NIDAC laser is not going to be designed for this. You can't get, you need coaxial illumination. Your beam has to be coaxial like that. And you gotta, exactly where that shot's going to happen. And so as far as mentorship, there's not really formal mentoring on this because it's off label. I have trained doctors either remotely or in person or at Academy of Ophthalmology, but it's so hit or miss. And now the reps for the companies have been told they're not supposed to be promoting it because of FDA. And, it's hard to get trained up on this. It's not that hard to do, but you have to be open to learning this. And I'd love to give a talk on this somewhere, but none of the laser companies don't want me talking about it either because of the FDA stuff. It's really hamstrung us. And I've tried to get into training programs and they won't let me in. So I've asked, they'll just say, oh, we'll get back to you. And then they don't get back. So I'd love to train people up. If anybody listening to this wants to learn about it, I am happy to share all my knowledge in specificity how to do this, but it has to be a doctor-to-doctor thing.
For patients who aren't candidates for laser vitreolysis, what alternatives exist, and when is it appropriate to refer to a retina specialist for more invasive options like pars plana vitrectomy?
Okay, so there's only pretty much, there's three options. One is the standard, you'll get used to it, which a lot of people do. And then the laser, as you get better and better at doing this laser vitreolysis, you'll get beyond just the Weiss rings and get into like more syneretic floaters in the front. But if somebody's got a big, massive bucket handle vitreous base thing that you can't get to, or just a huge floater, I kind of say, well, we can try this laser, but you're probably going to end up with a vitrectomy. I mean, a lot of people can get used to it if you give them the options. If you presented the options and they still say no, that's on them. They've been given all the options, right? But I do have to warn them if they're going to get the vitrectomy that if they're phakic, they're going to need a cataract surgery within a year or two. And sometimes you end up chasing your tail. No, you got an engineer in there. They're really annoyed with this floater. And now you're going to have them have a vitrectomy and then get a multifocal lens. And now they don't like their glare and halos. I mean, is that a better place to end up? So you got to be careful what you wish for. So I go through that with them. If they're pseudophakic, it's a no-brainer. Just get the vitrectomy done. You can suffer with this as long as you want, but if it's really bothering you, just get the vitrectomy done. I feel like the risk is relatively low with a good retinal practitioner. I'm not a fan of the Vista one-step. I know there's a lot of doctors interested in that, where on a pseudophakic patient, you may not have heard of this, but this is from MST. You put an anterior chamber maintainer in, and you're doing a blind stick vitrectomy behind the lens implant.
Oh, wow. Interesting.
Oh, it's been out for a few years. And I mean, if you're in the middle of nowhere and they have no retina people nearby, that might be a good option. I feel like where I am, I got all these retina people everywhere. I would hate to get a tear from that and then send it to retina. It's not a good look. So, right, I'd rather have the retina people. Maybe that's just me, but I'll send these people to retina. Now, I have talked to the retina people, and I wanted to do a video like this with them where I had like a floater laser doc and a retina doc. And the retina people I talked to while they do it, it's like a taboo area of retina where they're not wanting to talk about it openly. They'll do it, but they don't want to be known as the retina doc who does the floater removal, right? There's one I can think of in Kentucky who's out there promoting it. All the rest of them are like, they'll do it, but they won't talk about it. It's like that. So it's weird for patients. Anyway, I know you got to partner with a retina person willing to do it. Be careful not to send the really I just learned this, the ones with the psychological issues, don't send them to retina. Get them ruled out and say, this isn't going to work for you because they're not rational. They got to be rational, right? For us or retina, they got to be rational with what their expectations are. So there's some psychological profiling that goes into this too, that I've just recently sort of picked up on finally. Because people always talk about that. These people are crazy. I'm like, no, 99% not, 1% maybe. Then you got to watch out for the 1%, right? Just be aware of the 1%. But you want to partner with a retina person willing to do this for you or with you. Yeah.
And finally, let's address the business and risk side. What are the realities of reimbursement versus patient pay models for floater treatment? And what best practices keep patient safety front and center while minimizing liability exposure?
Okay, so that's a good point. So there is a code. I won't get the specific on the code. I can give people the specific code if they ask, but there is a code that you can look it up. It's for severing of vitreous strands and adhesions with laser, which applies to this. But if you ask a billing specialist, they'll say it's only for anterior segment. But you can use it as a posterior segment code. I have for 20 years. It works. And the reason I use the insurance is because it just gets patients doing it. I don't want there to be a barrier. To me, this feels more medical than it does cosmetic. Like, I feel like multifocal lenses and stuff and laser-based cataract surgery, that feels cosmetic to me because I don't want to wear glasses. This feels medical. So I feel like I want to bill insurance if I can. If there's an insurance that won't cover it, we will do an ABN. Like I know Aetna's a trouble I think it's Aetna or Cigna, but no, it's Aetna. They don't want to cover it. And we just happen to do an ABN and we charge them, I think it's like $1,000 to pay for it. It's a 90-day global if they want up to 3 treatments. And that's how we do it. Now, floater only doctors that only do this, they'll charge $2,000 an eye and they'll charge for the consult, a couple hundred for the consult. And they'll include, 3, I think there's like 3 treatments included there. And then they can a la carte beyond that. Once you get to 2 or 3 treatments, you're not going to do any better on the 4th or 5th treatment. It's just not going to, you need a vitrectomy at that point or get used to it, right? So, but on the financial side, it really adds a lot. Once you start asking people about this and normalizing it for your patients, you'll be amazed at how many are already in your practice ready to go. They've been annoyed with this for years. Nobody asked because everybody's blowing them off, and suddenly you're asking, like, yeah, I'd like to get rid of that. Well, we can do that. Start with your Sudafakes and your Weiss rings, easy Weiss rings, and you work your way up over time. It just takes openness and interest, but it will add a lot of revenue. I mean, if you're doing, I probably do, I don't know, 5 or 10 of these a week. My partner does another 5 or 10 a week. I mean, it adds up, and I've gotten good. I use it to 1 and done. Sometimes it's 2, but I don't get to 3 treatments hardly. I mean, if I get there, I'm sending to retina, right? At that point. So you're not on the hook for a lot. You do have to watch out. I mean, complication wise, when you're starting, you can get a retinal hemorrhage. I just got a retinal hemorrhage last week and it's a little tiny blood blister. It might leak a little bit, but as long as you don't hit a vessel, you're fine. As long as you're not hitting the fovea, you're fine, right? That thing will reseal. It's not a big deal. It looks worse than it is. But it can happen. I mean, if you get too close to the retina, if you hit the lens, if it's a phakic patient, you're going to get a stellate cataract within a week. It'll be a stellate cataract, and it's like a posterior polar, no posterior capsule. So you've got to treat it like a posterior polar and shell it out, and you can put a sulcus lens in, and it's okay. The modern lasers won't do that. You're not going to hit a lens. You might still hit the retina if you get too close. But usually you're in peripheral retina there. You're not usually near the fovea, so it's fine. It's just you got to be okay with a little bit of that risk that's potentially going to happen. That's why it's good to have retina backup. I mean, it'll freak somebody out who's never seen it before, but I've seen it before, so I'm used to it. But again, don't get too close to the retina and you'll be fine. If you stay mid-vitreous, you're not going to have a problem. If the floater starts moving back toward the retina, you can start seeing retina, just stop, have them come back in a month, wait for it to float forward again, and start working on it again in a month. Just give it a month and it'll move back. It'll move around. So there's a risk management to this too, beyond the financial, but it does. I look at it not financially. I mean, it is a good thing for the practice financially, but it's really a huge service for your patients. And if you got multifocal patients out there and you've caused their floater because of the cataract surgery you just did, this perfect cataract surgery, and now you can fix the floater, I mean, it's a pretty good add to your premium practice, I think. So that's how I look at it.
Well, in addition to you, I mean, you shared you do about 10 vitreolysis procedures a week. You have your partners do pretty much the same. Well, I know two doctors outside of learning that your volume. There's one here in South Florida in Boca Raton, and there's another one in City Industry in Southern California that I know that it's part of what they do on a weekly basis with the kind of volume similar to what you do. So I think it just speaks to, if it's something you focus on and get really, really good at, you can offer it in confidence and help out those patients who are really struggling with floaters and the troubles that come with them.
Yeah, and it's a horribly unmet need in our area of medicine. It's one of those things where I'm just amazed how long it's taken to catch on. I've been doing this 20 years, and that it's taking this long. In the old days, doctors would hear about something, and they'd all try it, and they potentially get good at it. But nowadays, it's like you got these KOLs and people waiting for Alcon to do something, and it's like, the doctors aren't there figuring stuff out themselves. They're waiting to be presented with something from industry, right? And if industry's not going to solve this, we got to solve it ourselves for the patients. So that's it.
Dr. Wood, this has been an incredibly rich conversation, from the evolution of cataract surgery and AI integration to the nuanced art and science of treating floaters safely and effectively. You've shown us that innovation isn't just about new technology, it's about thoughtful implementation, patient discernment, safety, and long-term vision. And perhaps like playing the trombone in an ensemble, great ophthalmology requires timing, harmony, and knowing when to step forward with precision. Thank you for sharing your experience, your insights, and nearly 3 decades of wisdom with our audience today.
Thank you for having me on. I appreciate it.
For our listeners who want to connect with you, learn more about your office-based surgery, or discuss floater treatment, where can they reach you? And please share your email, social channels, or where our audience can follow along.
So, yeah, I mean, basically, you can just email me at my Yahoo account. So it's drchriswood@yahoo.com. So drchriswood@yahoo.com. That's my email. Social media-wise, my practice has, but I don't have one specific for me, but it's Northwest Eye Physicians. So it's www.nweyem as in Mary D.com. So that's my practice one, but I don't have one specific for floater or OBS. But we have all that stuff in there. And I've got a video I made on Rendia, which is a vitreolysis video, which is really good. And if people contact me, I can get them my PowerPoint on this to get them started. Also talk to them through it. And also I have a consent, because OMIC doesn't have a consent on this. So we made our own consent, basically.
If today's episode flipped a switch in you, whether it's transitioning to office-based surgery, vitreolysis management, or building a practice that evolves with the times and has staying power, reach out to Dr. Wood and keep the conversation going. To my dedicated audience, as you know, the Q-Switch Conversations podcast is my way of giving back to an eye care industry and community that's shaped my career, my perspective, and my passion for what we do. This platform is truly built for you. The clinicians, the innovators, and change makers redefining what's possible in our field. So if you've got a fresh perspective, a unique experience, or know someone doing great things in eye care, I'd love to feature them on this show. You can hit me up on LinkedIn or drop me a line at d.spence@meridian.ch. As always, we'd like to thank Riverside.fm and Passionate Media for making this show happen, and of course, Meridian Medical for making it all possible. That's a wrap for this episode of the Q-Switch Conversations podcast. Until next time, this is Spence, and I am out.
You're listening to The Q Switch with your host, Spence.